All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today, our topic is on navigating the bedside teaching role as a hospice and palliative medicine educator. And to do that, we have two outstanding guests today. First, we have Dr. Andrew Lawton. He is a palliative care physician at the Northwestern Feinberg School of Medicine and the Director of Palliative Care Professional Development in the Division of Hospital Medicine. Andrew's clinical and academic interests focus on bedside teaching of communication skills and the professional development of clinician educators. Welcome, Andy.
Thanks so much.
Absolutely. Second, we have Dr. Leah Rosenberg. She is a palliative care physician at Massachusetts General Hospital in the Dana-Farber Cancer Institute. Her interests include the integration of palliative care into general internal medicine practice, medical education, and psychological issues in seriously ill patients. Welcome, Leah.
Thank you.
Absolutely. So our format for today is going to be a short and sweet presentation, followed by an opportunity for some questions from our live audience. And so with that, we extend a welcome appreciation, and I'll hand the mic over to you two folks.
Marty, thanks so much. And I think I can speak for Leah and I, we're really delighted to be joining you all and to share this session, which we've called what we notice novel opportunities for bedside teaching as palliative medicine educators. Leah and I have been peer mentors for each other as sort of co-clinician educators, co-teachers who really find it to be a privilege to get to work with learners when we're seeing patients and families at the bedside. And we've had a chance to think over the years about what comes up in the room when this teaching goes well. And I think our hope for this session is to share some of the insights we've come to in our own teaching and clinical practice. We'll think through a couple cases together and then hopefully leave time at the end for folks' reflections on these or your reactions to what's come up for us. So let's dive in. To provide just a little bit more context, well, first let's talk about some objectives. The first objectives for this session is to reflect on your role as a hospice and palliative medicine clinical teacher. That might be a traditional role like working with a learner when you're seeing patients in the clinic or in the hospital. That may be a job as a staff member where you're onboarding a new member of a team. Or working with nursing students in a course that you lead. We're going to think about what makes clinical teaching challenging. We'll think about two particular challenges and what can we do to sort of enhance the gratification that we as teachers feel. What's gratifying about this work? And when tensions come up, how can we stay connected to what is most fulfilling about being a clinical teacher? Leah's going to think with us about ways to identify small everyday moments, what we're going to call small moments for communication teaching, and we'll talk about that in a moment. And then in the latter part of the talk, we hope that you'll come away able to describe the teacher, learner, patient triad as a frame for clinical relationships that we as hospice and palliative medicine educators navigate. Just a little bit more context about sort of how Leah and I got connected. We were first connected in, I think, 2019 by a shared mentor who knew that both of us at the time were both doing a lot of clinical palliative care, as well as attending for a few weeks a year on the general medicine wards at our respective hospitals. So Leah and I first started talking about, I think we thought we would support each other around what's particularly difficult about not being a full-time hospitalist, but trying to do this general medicine sort of ward time and teaching. And what we noticed is that initially we were talking about how do you squeeze in a little bit of palliative care teaching while you're on general medicine ward rounds. And over time, what our conversations evolved into was something a little bit broader, where we found ourselves really interested in understanding and describing what is this work that we're doing as clinical teachers in palliative care? Again, starting with our work in general medicine, but over time morphing to the questions on the right side of this slide. What does effective bedside teaching look like in our field? What unique challenges do we as educators face? And again, as we said at the beginning of our time, what's happening in the room for learners, for teachers, for patients and families when clinical teaching goes well? We're going to think about two cases. There's like so much we could say about this topic, but we're going to think about two cases that are actually drawn from our own clinical experience. These are cases that we sort of have some made up names and made up teacher names, but these are things we've actually struggled with as teachers, and we'll share some insights we've come to. We would love your reactions to this content as well. The first case that Leah will take us through, we'll call sort of don't let the moment pass you by. What are the small moments for clinical communication teaching that we can find in our practice? And in the second case, I'll help us think about what are some of the losses and gains that we as teachers face. As palliative care teachers, there's some things we have to give up by the nature of sharing the visit with the learner. That can bring up some challenges, and what are the opportunities we have to recover some of the professional satisfaction that's lost by allowing the learner to take the lead. So two cases. For each of these cases, we'll share some details. We'll let you know what Leah and I were struggling with, a few insights we've come to, and then we'll be sure to save some time at the end. Leah, maybe I'll pass it to you for our first case.
Sure. Thank you so much, Andy. And we are so thrilled to be here. So one of my mentors once said to me, who was a psychologist, said, it's good to get interested in the boring. So when cases that you feel, oh, they're of limited teaching interest or they're just like an everyday quotidian, like I've seen this a million times, like that's the case to really get curious about. And so case one is drawn from our experience and we're calling it Don't Let the Moment Pass You By. So as we go through the case, really take note of all kind of like the small moments that are built into this very common scenario of clinical bedside teaching and write into the chat as you're able, any words, phrases, anything that comes up for you, ideas about communication or primary palliative care skills that a trainee might benefit from. Like even just the tiny little moments. What would you highlight as an educator? So you are supervising the general medical ward care of Ms. Holloway, a woman with dementia who's admitted with an aspiration pneumonia and approaching end of life care. You return after rounds to offer support to the family and the patient and answer questions. You offer to call the primary care clinician to update them on Ms. Holloway's decline. During the time that you're the supervising attending, the patient dies and you phone her daughter to express condolences and then engage in some brief life review. So, you know, this is such an everyday case, but what we were hoping is, what comes up for you as the supervising, clinician, like what small like moments would you highlight? So Marty is saying, what is the primary team's emotion? Like, what is the experience of the residents? Are they even able to verbalize those emotions? I think like that is in many ways a teachable moment. Anything else coming up for folks? Fear of starvation. So Marty's also identifying this is a really common issue that clinicians have to communicate around with families of patients at end of life. What does it mean to not feed the patient in dying? Do your trainees have the words? Do they have like the nonverbal skill set to support this family? And how do you know as the educator?
Leah, I'll add one thing I remember struggling with is like, of all these parts of the case, how much am I going to try to bring the students, the residents into this, and how much am I going to try to tackle on my own is like another thought that comes to mind.
Absolutely. Yeah. And going back to this idea of, well, this is such an everyday case. Like, this isn't a, puzzling diagnosis per se. How sometimes the whole frame, the educational frame of this case is, of issue. Is this a teaching case or not? Eve writes, honored but fear of unknown response of family. Yeah. And I think again, going back to the level of, I think some of our trainees may be anxious about, coming up against an unknown reaction and a strong emotional affect reaction from families. So what we notice is that small things count too. So, as Andy points out, it's tempting as the attending, as the supervising doc to, I'll take care of it myself. I'll go back later. I'll connect with the family. even that phone call to the primary care physician, even that, email to the renal doctor of the patient just to let them know what is happening. Like these are micro skills that our trainees would benefit from greatly. And daily practice has many, many small moments if we look for them, if they're there. But historically, a lot of our serious illness care teaching has been focused around like these threshold moments, like the family meeting or breaking bad news or conflicts that escalate to an ethics committee level. But there's so many small moments that they make up the fabric of clinical practice, and our trainees are hungry to really develop this skill set. And be able to speak to people in more empathic and competent ways. So, again, this is all, hidden in plain sight in a way, but these small moments are everywhere in our daily practice, and so Andy and I, as educators, we're often thinking about the ACGME, sort of the core capacities that we were wanting our trainees to have entrustable independent skills around, and patient and family communication. Well, these small moments, there are so many, daily updates, delivering difficult, if not devastating news. But, even things that we may think are minimal, like the diagnosis of diabetes. I remember as a resident being very shocked where one of my clinic patients began crying when I shared the hemoglobin A1C indicated diabetes, because to us, like we're kind of new to that emotional import, responding to affect, emotional distress, and providing education about a condition, that on lots of different levels. This other huge bucket, interprofessional and team communication, we're really uniquely poised in palliative care and serious illness care to uplift our trainees in this area. So discussing care with nurses, physical therapists, occupational therapists, chaplaincy, discussing care with consultants, connecting with the longitudinal space, and then professional disagreements, that comes up quite a lot. And as palliative care, clinicians, serious illness care providers, we kind of see that 10,000-foot view and are able to kind of bring in the diverse voices of different consultants. But that is not a skill you're born with or you come into internship with. That's something that has to be developed. And then support of colleagues distressed by a case. And I think you could have a whole hour just talking about this last one, and what the healthy boundaries are, and when peer support is needed, and when other referrals are more indicated. But I think the big thing, Andy and I talk about between ourselves a lot, is that rich teaching can happen in these small moments. They're micro skills. And so highlighting, interprofessional communication and that interpersonal communication through daily practice. And, instead of saying like, gosh, we never had a big family meeting, so I don't feel like my medical team, developed their serious illness communication, we would encourage you to say, but what is there in the everyday? It doesn't need to be a big DNR talk to really move our interns and residents skill set from, a beginner stage to a more seasoned stage, and then increasing opportunities for trainee observation and feedback. When that phone call to update the family member is made, is there a way that we could partner with our senior resident, not in like a judgmental way, but just in a real opportunity to uplift their communication skills? So, several strategies can help us. Oh, sorry. Setting goals, using language like during this rotation, I'd like to make sure we have time to practice and debrief our communication skills. Communication is something very different than managing hypernatremia, because sometimes it feels very personal. I mean, that was my experience. But I think that if we level set with our trainees that this is just something that we're going to be working on continuously through this rotation, they'll be ready for it. And it won't feel like, oh, I messed up. Anticipating the moment and anticipate building in pauses. So, thinking about, what kind of conversations do I anticipate today? We're going to go see Mrs. Jones, and, we have found that there's progression of, whatever disease, even if it isn't something, potentially fatal, worsening of vascular dementia. So, how do I anticipate these conversations? And then working in the pause. And it doesn't have to be a super lengthy time, but, you know, pausing before the encounter and just, saying to an intern, a resident, a medical student, what kind of interpersonal communication moment may this encounter, provide? Like what could be engendered in this even brief communication? Thinking about how are you in the room? What kind of time are you going to spend and how are you going to spend it? And preparing for the encounter together. This is really a co-creation idea, but saying to a trainee that you feel has the skill set, let's have you take the lead. If you're feeling stuck, you can ask me if I have anything to add. Sometimes I'll like make a joke of it and I'll say, you're the trapeze office, excuse me, you're the trapeze artist and I'm the net, and they get like a little laugh. But really what you're saying is like, I'm here for you. I'll jump in, but I really feel like you can try some of these training wheels a little bit and take the lead. Debriefing as a standard operating procedure. It doesn't mean you did anything wrong. Actually, this is really about the process of continuous improvement. So what went well? What might you have done differently? And what are you taking away from this? And another thing I would throw in is, did anything surprise you? Because of course, like there's so much content there. Okay, so the bottom line is palliative care happens in these moments, these really, really precious moments that give us a lot of the, sort of positive affirmation that we take away from this work, as well as like the big family meetings, the threshold moments, the, tough talks with oncology present, things like that. And these moments really, they ask a lot of us, clinicians' communication skills, but also as educators. And, I think the more we can seize on these small moments to enhance our communication skills training, the more we can also model that for our senior residents who can in turn teach interns this way, that it's not all about like the big, huge moments, but it's also just those micro skills too that are so critical.
Awesome. Thanks, Leah. I'm going to jump into our second case. So first case covering this idea that we don't have to wait for the big moments to do some communication teaching. There's a bunch of small moments in daily practice that can be worthwhile teaching opportunities. Now we're going to think about gains and losses. So here's the other case. Let's imagine that you are now a palliative care clinician. We're going to say you're the physician today, the attending, and you're working on the inpatient consult service with Dr. Stewart. And Dr. Stewart's a palliative care fellow. You're taking care of Miss Rhodes. She's a middle-aged woman with metastatic ovarian cancer. She has progressive disease. You've been addressing her pain and checking in about her illness understanding, asking a little bit about her hopes and worries about the future. And during these conversations, Dr. Stewart, the fellow, mostly takes the lead, exploring Ms. Rhodes' concerns, while you as the supervisor are sort of perched on the patient's windowsill. Maybe that's a spot that's familiar for some of us. As the attending, you largely observe the conversation. You might occasionally jump in with a clarifying question or responding to the patient's emotion, but you mostly let the learner take the lead. And after the visit, in the way that Leah was describing, you probably debrief with the learner, talk about what went well, talk about what they could do better, do differently in future communication. And at the end of the week, there's a family meeting, and you and the oncology team talk with the patient and family about the recommendation against further cancer-directed treatment and suggest referral to an inpatient hospice facility. Now, here's where it gets interesting. The fellow, Dr. Stewart, leads that family meeting really beautifully. There's occasional support from other clinicians in the room. And at the end of the meeting, as the clinicians are preparing to leave, the patient takes the fellow's hand and says, Dr. Stewart, thank you so much. You've helped me so much. Driving home later that day, you as the attending find yourself reflecting on the case, and you notice a little bit of a twinge of emotion when you think about all the effort you took to make sure this patient got excellent palliative care. Made a little bit more complicated by the fact that it was actually the learner who was the recipient of the patient's gratitude. And you feel both proud of the learner and also a little bit empty about your own clinical bond with the patient. Can this all be right at the same time? In the interest of time, I'm just going to jump to what Leah and I noticed in this case. We as clinical teachers, the first box here is an obvious one. We have to navigate simultaneous relationships with patients and learners. But what that means is that we also have to give up the satisfaction of working one-on-one with the patient and family to allow the learner to practice their skills. And that can feel like a loss, especially for a lot of us who probably got into palliative care because we once wrote a personal statement that was like, I want to help patients and families in their time of need. I want to connect with them. And now we have to step away from that. What we also find, and what we're going to argue, is that we can recover some of that professional satisfaction by investing differently in our relationship with learners. Okay, let's look at this a little bit more closely. So teaching encounters exist as a triad. There's, of course, the patient and the learner on the left side of the triangle, and especially with our more advanced learners who can run a lot of the conversation in the room, it's going to feel to the patient appropriately like the learner is their primary clinician. That bond is strong. The teacher-learner bond across the bottom, also strong. We're partnering in patient care together. We're partnering in expanding the learner's skills. The relationship that's a little bit less strong is the patient-teacher relationship, where the teacher's intentionally stepping back, sitting on the windowsill, allowing the learner to take the lead, form a connection, stretch their skills. Doing that work, stepping back as the teacher, requires some things of us as educators. I have to tolerate the looser bond with the patient. This isn't my moment. This is the learner's moment. I have to refrain from using some of my own skills. That means I have to tolerate in a visit that might be a little less efficient or might even have a communication misstep or two compared to what Dr. Marty might do on his own without a learner in the room. And I have to gauge whether to interject. If I do interject, there's always the risk of de-skilling the learner. Sometimes you have to interject because it's part of safe and effective care for the patient. So lots of self-restraint we have to exercise here as teachers. So if we are facing some less connection with the patient and family, what can we do to recover some of that professional satisfaction? Well, we would argue that we can invest differently in our relationship with learners, and we'll talk about a couple ways to do this before we wrap up. The first is we can shift some of our attention from the patient to the learner. And what we mean here is that, on the one hand, this might sound obvious. Of course, I'm going to observe the learner while they're in the room so we can debrief. Of course, I'm going to keep an eye on what skills are working, what they're struggling with. What we actually mean here is something a little bit deeper. As palliative care clinicians, many of us think of our job as going in the room, scanning for the distress, and figuring out what is the intervention. How can I be helpful? What I'm doing here now as the teacher is shifting some of that intention to be helpful from the patient to the learner. I still need to make sure the patient's getting safe and good care, of course. And I'm going to shift my attention a little bit and ask myself some questions about the learner that I might normally ask about the patient. What does this learner already understand? What are their goals for this encounter? How can I be most helpful in making sure they have an effective and didactic encounter here? What we find is that when we shift some of our attention in this way, I'm still keeping an eye on the patient and family, of course. I'm a clinician, that's my job. But when I shift my attention a little bit, I can help recover some of that professional joy, and I can reconnect with how am I going to go in this room and be most helpful today. The second two pieces here of how to, again, reconnect with the professional satisfaction that's inherent to being a teacher is really what Leah talked about. Investing in learners means that we're pre-briefing before we go into the room and we're debriefing after we come out of the room. And I'm just highlighting here some of that same language from the Vital Talk framework that Leah highlighted earlier. If you're feeling stuck, I'm right here for your support. You can look towards me, and afterwards, what went well? What might you have done differently? What are you taking away? Or as Leah added, what surprised you here? The last two things then, in terms of investing in our relationship with the learner, is that making sure I have sort of enough professional satisfaction of a teacher also means that sometimes I need to see patients on my own. And in fact, learners need to do that too. Preserving some independent clinical time allows me to not only experience that one-on-one connection that I lose when the learner's in the room, but I also need to refine my skills. I need to struggle. I need to recover. I need independent time with the patient and family to keep working on my own practice. And learners need it too. We know that we remember being a trainee, right? You could take different risks. You could try new things in the room without always being constantly observed. When your supervisor wasn't in the room, you're freer to try new things and make different choices. And then the last one is leaning into informal moments between encounters with learners. So what we find in our own practice, and I wonder if this resonates with folks, is that, it's often that elevator conversation about, how we find sustainability as a palliative care clinician, or the hallway conversation about what's it like to take care of young, sick folks day in and day out. Those are often those informal moments are the moments where we find, gosh, the most meaning and connection and fulfillment in working with our learners. So really taking notice of those informal moments and leading into them. So bottom line for the second case, what connection might be lost with the patient and family when we're working with trainees can be recovered by really investing more intentionally in our relationship with learners. Shifting some of our focus from the patient to the learner allows teachers new opportunities for professional fulfillment. Leah, do you want to just highlight these two last points and then we'll open it up for some reactions?
Yeah, absolutely. And we'd love to hear, all of your thoughts and feedback about this. So, key points from this kind of bite-sized talk is that partnerships across institutions can be so fruitful, that sometimes we get a little siloed in our thinking, but in, smaller specialties such as HPM, it's really important to remember that, we have thought partners and, kindred spirits across the country, even internationally, that we can partner with for academic niches. And then, I would say my big takeaway is that we can be great educators by thinking small. And sometimes, these little moments can be so impactful for our trainees. They can be easier to tackle. They can feel a sense of accomplishment and development. And it's a real unique place to offer support. And then investing in that teacher-learner relationship that Andy spoke about can give such a sense of meaning on fulfillment on the professional level, even when the primary bond of the relationship may not be with you as the educator anymore, but rather with a very engaged trainee and the patient and family. But recognizing, what is gained and what is lost is so essential to being a great educator. So with that, I'll stop talking, and I would love, we're a pretty small group here. I'd just love to hear about your experiences, educating, or thoughts that come up, or questions, or anything at all. And we really thank you for your time and attention today.
All right. Thank you too. I'm going to start us off with a question, give people some time to think about what they'd like to ask. My question is about physical harm versus psychological harm for the patient. And so you comment in your paper briefly about communication errors that might require some repair. And I think about, if I have a fellow, I am not going to let them write an order for a med that might cause some physical harm. We'll talk about it. They may have an opportunity to guess something that would be incorrect, but we would never go down that pathway. And yet, I'm going to let my fellow go in and communicate and potentially cause some psychological harm to some degree, depending upon how they approach it and et cetera. Do you think differently about comfort? I don't know, potentially causing harm in different ways to patients? How do you conceptualize some of the stuff?
I'm happy to share a thought or two. I guess maybe two thoughts. My first, and I imagine these are things that folks would readily agree with. I guess my initial reaction is like I do have to remind myself that my first responsibility is to the patient and family. And so while I want to find skillful ways as a teacher to sort of redirect an idea inside the room or outside of the room that might be harmful, hopefully I'm preserving for myself this idea that my first job is to the patient and family as a physician or as a nurse. And so that might mean a little bit of discomfort for the learner. I don't want to make them uncomfortable, but I may have to name something that, feels a little bit uncomfortable. My other observation is, over time, I find myself this is just editorializing. I think as we gain experience, we can give learners more latitude and trust that we as the teacher can recover. Saying in the room, I hear what Dr. So-and-so is saying. I wonder if I could add a thought or two about, in case plan A doesn't work, I want you to know we have a few other options in mind. We have a few other ideas of how we can be helpful. And in fact, I'm even going to say we're going to try one of these even before the thing that, Dr. Mary suggested. I think over time we can find ways to recover or even allow the learner more space and still trust that we can recover in the room. But I don't know if there's other thoughts folks have on that.
Just to make one point too, and Marty, I love that question. It's a very, very interesting one. One of the things I have learned is that there's this value in psychotherapy about rupture and repair, and that actually these moments that don't feel 100% comfortable actually can be most evocative, most helpful for even development. When a patient kind of even has a communication breakdown with a provider, if they're able to talk about it, if they're able to move forward, and that's where having the experienced educator present can be so helpful, that actually if the rupture is able to be repaired, if it's not too egregious, then you know let's say the fellow says something that just doesn't land, and as an educator, you witness it and you're able to name it, to say, and Mrs. Jones, like I noticed that, your face changed expression, or I noticed that it was hard to, speak about that topic. I'm wondering like what's coming up for you, always realizing that what we're modeling for our trainee is also it's okay to mess up, or the messiness of communication is part of what makes it powerful, because it's actually this very human moment to have. So I don't know. So I think it's something that I'll probably reflect upon quite a bit, the harm question.
Can I also get your thoughts on if there are certain things that we should or should not be shielding our fellows from? Because I remember when I was a fellow, there was this thing called the gray hair consult. And I didn't have a full head of gray hair, so I wasn't allowed to do those consults. And so I don't know exactly what they entailed, but I assumed it was probably incredibly well-known landmines in politics within the hospital of some sort. Do you guys shield your fellows from certain things? Do you try to bring them into that so they're not having to figure it out for themselves when they're thrown to the wolves when they're an attending at some point?
I guess uh, things I noticed myself shielding
Mm,
learners from recently, or maybe in the past few years. One is if there's unprofessional behavior, especially on the part of, and many of us might readily agree with this, but I
mm,
find myself stepping in and sort of taking over if it feels like, especially someone who's higher than the fellow in the hierarchy, if they're being particularly strident or even bordering on sort of unprofessional, I think that's when I step in and say, whether it's over the phone or in person, to say, I just want to jump in and add my own sense about what's going on here and how we can best move forward. And then this one, I don't know if I'm doing it right or wrong, but sometimes if we're taking care of like the quote unquote VIP patient, or really, uh, you know, patient or family with very high demands, or super critical, I think that's a moment. I don't know if I'm right as to do that as the teacher, but I find myself feeling protective of the learner when we're in the like VIP space, whether that's a good or not good space to be in to begin with.
mm.
I don't know if that are those the kinds of things you're thinking about, Marty?
Um, I feel like this is somewhat of a universal subject. I've heard other fellows say that, like they felt as a fellow, they were shielded from certain things. Um, and I don't know, maybe to some degree that makes sense because I'm 9 years out of fellowship now,
Yeah.
and I feel like there are certain things even now I would do differently than 5 years ago as an
Okay.
attending. And so I don't know, there's something I think to be said about a senior, I don't know, a senior palliative care attending addressing certain things in certain ways. Though it would be really lovely as a fellow to watch that and observe it and to
Yeah.
grow from it, even though I'm not sitting there in the frying pan.
I also think I remember someone saying to me when I was a fellow, like at the end of my fellowship. I think we must be similar because I think I'm 9 years out as well, Marty too. But I remember this someone saying to me, "You're only going to get to observe this much for a little bit longer." And so I agree with you that I think when we're in particularly nuanced or challenging situations, I don't want to steal the learners every opportunity to stretch their skills, but when we're in a really unique, challenging situation, I think sometimes it's okay to be like, today, they're going to learn by watching Dr. Marty navigate this particularly nuanced situation so that when they're in it, they've at least had the chance to observe an expert doing it the best he or she can. And so I think my own reaction is that I think that's right. Some observation, even late in the training, later stages of training, is still helpful and it's appropriate.
Thank you. Eve, I see your hand is up. Maybe we'll have you be the final question for the day.
Well, I'm honored. Thank you. First of all, fantastic topic. The article, when I was reading the article and hearing Dr. Morgan as the teacher's perspective, um, it almost brought tears to my eyes because I think it's something I've kind of always thought. Full disclosure, I'm a nurse practitioner with hospice, and some of the challenges that I've had, and this kind of goes from the last point brought up, is the hierarchy and having, knowing what each individual brings to, some of these conversations. And I guess I'm looking for any advice on helping through a hierarchy, specifically from physician to advanced practice clinician, bedside nurse, social worker, different things like that, where perhaps the non-physician may have some more established time with the patient, family, and even the communication skills gained through the years, but still respects that hierarchy.
Oh, that's such a wonderful insight, Eve. I'm so glad that you brought that up. And I apologize if the language of the talk was kind of more physician oriented because it's drawing from our experience. But our fellowship is interprofessional, and I'm thinking of our nurse practitioner colleagues who would, of course, have a different perspective and a very interesting one to share. But I think that that's, again, like it's a unique strength of palliative care and hospice that because of our interdisciplinary model, that we don't exist in isolation. The more that we can, be kind of more on a parallel standpoint that, there's things that every clinician is going to bring to the interaction. But, I think about, when I have patients on inpatient hospice care and I'm the supervising physician, but the bedside nurse is really providing the moment to moment care and having those intimate conversations with family members. We need to sort of introduce in our trainees like a flexibility of role, that there's times where you're going to be like the point person for some of those more close to the hip discussions. There's other times where you need to ask yourself, how do I empower this other clinician to be the person? How I sometimes say to our trainees, when you're thinking about hospice care, the question is nursing empowerment. What do they need? How can I be helpful? How can I, help marshal resources or, provide orders that are, allow for flexibility. So again, I think that that's another like micro skill, is learning how to dial up and dial down our role in care.
Can I share just one story? And I promise to be brief, because I'm thinking about your question to Eve. I'm joining the palliative care team at Northwestern right now. It's literally my fourth day here, and I talked with one of the nurse practitioners that I'm going to be working with all the time yesterday. She was orienting me. She's extremely experienced. I'm like, I mean, I have some experience under my belt, but I'm brand new here. And I guess what the other strategy that came to mind yesterday is like, we kind of just named it. Like we talked openly about it. Like we're going to work together a lot, probably every other week on service. And she has an incredible amount of experience, also a lot of institutional knowledge. And I have certainly some experience, but I'm brand new. And so we actually were just naming for each other that there's like something a little bit clumsy about this, but hopefully an opportunity here for a lot of bi-directional learning. And so we hope we're really good at naming things in palliative care, but I found she and I yesterday just naming the little bit of tension around like, this kind of feels funny for both of us, but actually just talking about it openly felt like it lowered the emotional temperature. And I certainly look forward to working with this person. But I resonate with the hierarchy challenges, even in palliative care, strongly. And so thanks for that, Eve.
Lovely. All right. Leah, Andy, this was absolutely wonderful. Thank you for joining us today.
Thanks for having us.
Thanks so much. Have a great weekend, everybody.
Bye.
Thank you. Thanks, Marty. Thanks, everyone.